and welcome to Insight Ophthalmology. This is Dr. Amrit welcoming you to another lecture on the optic nerve. Today we are studying optic neuritis. What is optic neuritis? A demyelinating inflammation of the optic nerve is actually known as optic neuritis. The word that we should actually be focusing over here is the demyelinating. Okay, so it's not just any inflammation of the optic nerve. Specifically, the term optic neuritis is used when demyelination is associated with inflammation of the optic nerve. Right now, based on the part of the optic nerve which is affected by the inflammation, there are different types of optic neuritis. So if the optic nerve head or the disc is involved, it is called the papillitis. That is just the inflammation of the optic nerve head. Sometimes what happens is that the intraorbital part of the optic nerve will be involved, right, which is shown over here, and that is called the retrobulbar neuritis. So what I mean to say is only the intraorbital part of the optic nerve is involved and the disc is not involved, as in papillitis. The third thing is the neuroretinitis. In neuroretinitis, as the name suggests, the nerve is involved, that is neuro, and along with that the retina is also involved. So there will be disc edema, and along with that you will see certain changes in the macular area also, and since the retina and the disc both are involved, it is called neuroretinitis. So when I talk about the clinical signs of optic neuritis, I would be touching papillitis, neuroretinitis and retrobulbar neuritis in detail. So what is the pathophysiology of optic neuritis? The main word that we have to remember even in pathophysiology is the demyelination. Optic neuritis is caused mainly by the demyelination. So over here we have a picture of an axon, and we can see that this is the cell body and over here is the axon, and we can see that the axon is actually enveloped by the myelin sheath. Okay, and these myelin sheath is produced by the oligodendrocytes in case of the optic nerve. The presence of myelin helps in the faster conduction of the impulse through an axon. Now let us try to understand this pathophysiology in more detail, and specifically let us understand why does this demyelination of the optic nerve occurs. The first thing is understanding the blood-brain barrier breakdown. As we all know that the blood-brain barrier prevents the entrance of the T cells into the nervous system, right? So the blood-brain barrier is normally not permeable to these types of cells, unless it is triggered by some infection or a virus. So whenever there is an infection or there is a virus, what happens is that the integrity of the tight junctions of the blood-brain barrier will be decreased, and later on as the infection heals, the blood-brain barrier might recover. However, what happens is that these T cells will now be trapped inside the brain or inside the nervous tissue, right? So initially there was a blood-brain barrier and this was preventing the entry of these T cells and the inflammatory cells. But after an infection or after some virus infection specifically, what happens is that this will become more permeable and then these cells will come inside. Later on, as the infection will heal, the blood-brain barrier will again form. However, these cells are now trapped inside the nervous tissue. Next, what happens is the process of autoimmunology or autoimmunity. Now, the immune system will now attack the nervous system, leading to plaques and lesion formation. So what happens is these T cells which were trapped inside the nervous tissue, now they are going to go and attack our oligodendrocytes which were present around the axons and forming the myelin sheath. Right, so as these T cells which are just trapped, they are going to go attack to these oligodendrocytes. They will cause demyelination, and in the process of demyelination, they will lead to plaques formation. Okay, they will cause demyelinating plaques formation. And this process of demyelination will particularly affect our white matter. Okay, why? Because most of the axons are located in the white matter of the brain, and therefore these T cells will go into the white matter and destroy the oligodendrocyte. Now, the third step which occurs is the inflammation. That means the T cells which have come and attacked the myelin sheath, they're not going to stop just by destroying the oligodendrocytes, right? So they are going to trigger some inflammatory processes also and stimulate other immune cells and soluble factors like cytokines to come to that place, right? So this will cause further swelling, further leakage from the blood-brain barrier, further activation of the macrophages, and further damage of the nervous tissue, right? So these are the three processes in the pathophysiology of demyelination or optic neuritis, that is the blood-brain barrier breakdown, autoimmunology, and inflammation. So anything which can cause blood-brain barrier breakdown and cause finally autoimmunity leading to inflammation of the brain and finally demyelination can cause optic neuritis. Now this diagram explains the same thing. So this is the blood-brain barrier over here, and usually it will not allow the monocytes to pass through it. However, some systemic cause will cause the increased permeability of the blood-brain barrier or breakdown of the blood-brain barrier, leading to coming up of the monocytes inside the neural tissue, and then what will happen, the monocytes will develop into macrophages. These macrophages will get attracted to the myelin complex, okay, and then they are going to destroy the myelin sheath. Now the same macrophages again are going to come back and release some soluble factors. These soluble factors will again come outside the blood-brain barrier and they will call the other B cells and the T cells. These other B cells, T cells will now produce antibodies and they will produce other inflammatory mediators and cause inflammation of the myelin sheath, leading to further destruction and further demyelination. So histopathologically, we are going to see demyelination, right? So when we take a slide and see, in that we are going to see perivascular cuffing. Okay, that means there will be blood vessels, and around the blood vessels we are going to see cells. Okay, and what cells are those? T cells, B cells, and the plasma cells. And I told you why these cells are coming, right? At the same time, because these cells are causing inflammation will lead to edema of the myelinated nerve sheaths, right? Now as there is edema and there's inflammation, it will finally lead to myelin breakdown. This myelin breakdown is occurring because of two reasons. Number one is inflammation and number two is autoimmunity. Now, the demyelination in the optic neuritis can actually occur alone, or it can be associated with a lot of syndromes. Okay, now if it is occurring alone without being associated with any kind of syndromes, it is called clinical isolated optic neuritis or isolated optic neuritis. Okay, now as it is associated with multiple sclerosis, which is the most common association. Okay, so what I mean to say is, whenever there is an episode of optic neuritis, the first thing that most of the physicians will think is the presence and the probability or the risk of developing the multiple sclerosis in a patient, right? So this is the most common association with optic neuritis, and that is multiple sclerosis. Now, this association of multiple sclerosis with optic neuritis is so common that we usually label these patients who are isolated optic neuritis or with multiple sclerosis as the typical optic neuritis, right? These are called the typical optic neuritis cases. Now, the third association or third type of demyelination which can occur is in the neuromyelitis optica, also called the Devick's disease. Okay, so I will go into details of these subsequently. However, neuromyelitis optica, which is also called the NMO, is nothing but it is the presence of optic neuritis along with transverse myelitis. Okay, so there is not just inflammation of the optic nerve and demyelination of the optic nerve, there is also inflammation present in the spinal cord, and that is called the transverse myelitis. Now, another association with optic neuritis is the acute disseminated encephalomyelitis, which is also called ADEM. Okay, in this also we have optic neuritis, but what is typical with the acute disseminated encephalomyelitis is that there will be a history of recent viral infection or recent vaccination, and it is believed that there is autoimmunity which is triggered with recent infection or recent viral infection, to be more specific, and specifically in certain kind of vaccinations, okay, which will lead to autoimmunity and cause demyelination and finally cause the optic neuritis. Now, there are two important new antibodies in relation to the optic neuritis that we should be aware of, okay? And these are, number one is the antibody which is present against the astrocyte aquaporin 4 water channel, okay? And this is called the AQP4 IgG antibody, okay? It is called AQP4 because it is aquaporin channel 4, right? So this is seen in 2% of the cases with optic neuritis, okay? Now the second type of antibody which is important for us to know is the MOG IgG antibody, that is the myelin oligodendrocyte antibody, which is actually an antibody against the oligodendrocyte glycoproteins that will result finally in damage to the myelin insulation. So as I told you, that if these are the axons and around that we have the myelin sheath, this myelin sheath is actually formed by the oligodendrocytes, and if you have antibodies which are directly going and attacking these oligodendrocytes, then those are called the MOG IgG antibodies, and the association is 15%, right? So this is the new antibodies that we must remember, and they have a very important role in management of optic neuritis if patient is having these antibodies positive, and that is the reason why I want you to know about them in brief in the pathophysiology. One more thing what I want you to know is that the presence of aquaporin P4 antibodies and the MOG antibodies will actually make the patient fall to a category of optic neuritis which is not typical, right? So this is called atypical optic neuritis, okay? That is number one point. Number two concept which I want you to remember is that this aquaporin P4 IgG antibodies is usually positive in patients with NMO, that is neuromyelitis optica or the Devick's disease. Now, in a patient who has MOG IgG type of antibody, that is also atypical optic neuritis, and the optic neuritis is actually called MOG optic neuritis. Now, as I told you in the pathophysiology, that anything which causes breakdown of the blood retinal, brain barrier will actually cause the inflammation and cause demyelination. So it is very obvious to think that optic neuritis can also be caused by certain infections, and these infections can be both local infections and it could be the systemic infection. So sometimes there could be endophthalmitis and orbital cellulitis, sinusitis, and sometimes spread from the brain and base of the skull. So what happens is that these infections can either come to the optic nerve themselves, or the inflammation which is associated with this infection can attack our optic nerve myelin sheath and cause demyelination leading to optic neuritis. However, this, if it happens, it will again be an atypical case of optic neuritis and not a typical one. Now, there are a lot of systemic infection which can cause demyelination and can cause optic neuritis. So it could be viral, it could be bacterial, fungal, protozoan, and parasites. So out of these viral which are important are the influenza, measles, mumps, chickenpox, herpes zoster, cytomegalovirus, and in bacteria, in low developing countries, we have tuberculosis and syphilis, okay, and then we have cat scratch disease, the Lyme's disease, okay. Fungal, we think about cryptococcosis and histoplasmosis. In protozoal, we think about toxoplasmosis, malaria, toxocariasis, and parasites, we basically think about cysticercosis. So if you have to think about few infections, if you want to remember few, you can think about the measles, mumps, influenza in viral with cytomegalovirus and infectious mononucleases. And bacteria, you can think about tuberculosis and syphilis particularly. In fungal, we can think about histoplasmosis and cryptococcosis. Protozoa, think about toxoplasma and toxocara. And parasitic is only one, cysticercosis. Now, as there was a role of autoimmunity, as I explained you in the pathophysiology, so any kind of autoimmune disease can also lead to demyelination. So it could be systemic lupus erythematosus or polyarthritis nodosa. What happens is that there will be ischemia in these vasculitis cases, which will lead to demyelination, right? And then it can also cause necrosis, or it can cause demyelination and axonal necrosis both, right? So the clinical profile will actually look very similar to optic neuritis, okay, or they can actually have acute ischemic optic neuropathy picture also, because ultimately we are having vasculitis which is causing ischemia. So if the ischemia component is more, there will be ischemic optic neuropathy, and if there is an autoimmune component along with ischemia, that might cause demyelination along with the axonal necrosis. Now, there are a lot of metabolic causes and metabolic diseases which will lead to decreased nutrition, and that decrease in nutrition can again trigger autoimmunity and can damage the normal pathophysiology and lead to demyelination. Okay, however, this is very rare. Okay, so don't think it in the first differential. It should always be thought in atypical optic neuritis, and that too always in the end, whether it is anemia, B12 deficiency, diabetes, starvation, okay, and pregnancy sometimes, which can trigger autoimmunity. Now let us talk about the clinical features of optic neuritis. The first thing that I want you to remember is that they will have loss of vision, which could be subtle or which could be profound, but it is going to typically deteriorate over hours to days, and then it will reach the maximum trough in about 1 week after the onset, right? So very quickly it deteriorates and reaches its maximum deterioration. Number 2, the visual loss, as I said, could be subtle or could be profound, okay, and most of the patient can also have complete blindness. Then it is usually unilateral. Now this is what I want you to remember. It is usually unilateral. Yeah. Now at this point, I want to clarify that when I'm talking about the clinical features of optic neuritis, I am talking about the typical optic neuritis. Okay, so these are the clinical features of typical optic neuritis. Then one more important thing is the age of presentation, 18 to 45 years of age. And along with that, there will be pain, okay, deep orbital or retroocular or brow pain, which is aggravated by the eye movement, and it is increased by the pressure upon the globe. Now you might ask, why is there pain with the eye movement? So what happens is that the optic nerve is actually having the superior rectus and the medial rectus. They are present in very close association with the optic nerve sheath. So whenever there's inflammation of the optic nerve sheath, okay, there will be inflammation of these muscle fibers also, which are present in close association with the optic nerve at the optic orbital apex, and therefore whenever the patient will have eyeball movement, specifically when he tries to look up or when he tries to look medially, there will be pain. So other visual functions such as the loss of color vision, typically the red desaturation, okay, that is present. So I told you already that in optic neuropathy, usually red desaturation is present. And there's one more thing which happens is an altered perception of moving objects, okay, and this is called the pulfrix phenomena. Now what happens is that if we have two eyes and one eye is affected with optic neuritis, okay, so this axons will have damage to its myelin sheath. So as the myelin sheath is damaged, the conduction velocity will be decreased in this axon. However, this normal eye will have a normal speed of conduction, okay, or the normal conduction velocity. So what can be seen is that there is a conduction velocity disparity between the two eyes, right? So there is a problem in velocity perception. They cannot coordinate there's no coordination among the two eyes, because of which when an object which actually has a movement of its own, its perception would become difficult for the patient, and this is called the pulfrix phenomena. Along with that, some patients are going to complain of one more thing, which is worsening of the symptoms with exercise or increase in the body temperature, and this is called the Uthoff's sign. Okay, so what is thought is that when there's increase in the temperature, the inflammatory mediators will increase and will lead to more signs in these patients. So the patient will give history that usually after a hot bath or after doing exercise, what happens is the body temperature will increase and he will have deterioration of his vision. Now, what is the course of a typical optic neuritis? So what happens is that, what did I tell you, that the optic neuritis will progress within hour to days and will reach its trough, in about 1 week time, right? However, what happens is that from the second week onwards, it is going to start improving, right? So it starts improving from second to third week. Okay, so improves second week, improves third week, and by about fourth week or fifth week, the visual acuity is going to return to normal or near normal. That is about 618 to 612. Right, so it will progress very fast, reaches the trough very fast, and then starts improving by second to third week, and then reaches fourth and fifth week the maximum visual acuity, right? And this is going to happen irrespective of your treatment, whether you give steroids or you don't give steroids. The typical optic neuritis is going to follow this course. Now this is a very important point, and you have to remember the timelines also for the course of typical optic neuritis, because anything which does not follow this will fall to the category of atypical optic neuritis, and the treatment will be totally different. So next what happens is that subsequently the vision is going to vision slowly and steadily improves over several months and ultimately will be restored to 6/6. So improvement starts from the second and third week. However, the improvement by fifth week is up to 612 and 618. However, it will improve, it will keep on improving, right? So improvement is also progressive in these patients over several months. However, there is something which does not improve or which takes longer to recover, and that is the color vision, okay, the contrast sensitivity and the visual field effects. These three things will not get recovered so soon, and they are going to take longer period of time, that is about 6 to 12 months, and in some patients they might not improve or completely return to normal. So based on the clinical features that I have discussed, now I would tell you what do I mean by typical optic neuritis. So in a case of typical optic neuritis, the age range will always be 18 years to 45 years of age. There will be pain, and the pain is always mild, and that pain will become worsened or it become more on eye movement. The disc will usually be normal, or there might be mild disc edema. And the progression is very quick, that is from hours to days, and then the improvement will start from second to 4 weeks onward, and the improvement will be there irrespective of the steroid treatment, okay, whether you give steroids or you don't give steroids. And even after we stop steroids, there will be no recurrence. So these are the features of typical optic neuritis. Anything which is deviating from the typical features is an atypical optic neuritis. So if the age is present outside the typical range of 18 to 45, that means patient who is younger than 18 years or older than 45 years will fall to the category of atypical optic neuritis. Then the pain will be absent on eye movements, or the patient might have very severe pain. So severe pain also should alarm you that it might be a case of atypical optic neuritis. The poor vision will persist beyond 2 weeks from the onset. So in a case of typical optic neuritis, we saw that the vision was actually starting to improve beyond the second week. There will be progressive diminution of vision beyond the first week. Now, what did I tell you in optic neuritis? A typical variety was that within hours to within days, the vision is going to drop, and within 1 week, it will be the worst, and then starts improving from the second week onwards. Now, if there is a further drop after 1 week, then you should think that, okay, fine, maybe this is an atypical optic neuritis. And such patients, if you give steroids and if you don't give steroids, they are going to become worse. And if you give steroids and then you stop giving steroids, there might be recurrence, right? So such patients will also have bilateral involvement. So what did I tell you? A typical optic neuritis case usually will be unilateral. So whenever there's bilateral optic neuritis, you have to think in terms of a typical optic neuritis. Now this is all very important, because whenever there is a case of atypical optic neuritis, you have to think in terms of certain specific further investigations, because it might not be a simple multiple sclerosis, it might be other demyelination disorders, okay, which will need a totally different approach and a different treatment. Now, one more important difference is that in the typical optic neuritis, there was a mild disc edema without any hemorrhages. However, in atypical optic neuritis, you might actually see severe disc edema with the hemorrhages. Now, what are the various signs that you see in the case of optic neuritis? As I already told you that there will be a variable degree of visual acuity loss. decreased color vision, specifically the red desaturation, contrast sensitivity will be decreased, stereo acuity will be decreased, okay. Then the visual field effects might be present, and there are a varied types of visual field effects that you can see in optic neuritis. You can see central, centrocecal, arcuate, sectoral, altitudinal, or a generalized non-specific depression also. There might be a presence of Marcus gun pupil or the relative afferent pupillary defect, which is very common in papillitis, okay. And there will be on VEP, okay, visual evoked potential, the P100, okay, this will actually show prolonged latency, right? So what happens is that there will be increased latent period because the conduction velocity is going to decrease because of the loss of myelination. The latent period is also going to increase, right? So on VEP we are going to see delayed P100. Now, what are the ophthalmological signs that we see? That is, when we are actually going to see it using an ophthalmoscope or during a fundus examination, what are the signs that we see? Now, the disc could actually be totally normal in case of retrobulbar neuritis, okay, which is more common in case of adults, and it is shown over here in this picture. You can see that in this picture, the disc almost looks normal and there are almost no signs that we see. However, the patient might be having RAPD, might be having red desaturation, which should actually alarm you that there is an optic nerve problem. Right, so this is a retrobulbar neuritis, and because the intraorbital part of the optic nerve is involved and not the disc, we do not see any signs in the fundus. Okay, and it is more common in adults, and also it is more common in multiple sclerosis. Now, however, sometimes only the disc will be involved, which is called papillitis. Now, in that case, we will have a hyperemic disc with swollen disc margins. The margins will not be clear, and with or without flame-shaped hemorrhages, right? In which, if there are no flame-shaped hemorrhages and there is mild disc edema, it goes more in favor of typical optic neuritis, and if there are more hemorrhages which are present, it goes in favor of the atypical optic neuritis, right? And papillitis is more common in case of children and young adults. Now, sometimes what we see is that we will see involvement of both the retina and also the optic disc, right? So in that case, we will have the stellate patterns of exudates, okay, present in the retina, and this thing is called the neuroretinitis, okay, and probably the etiology over here is infectious etiology, right? And also this presence of neuroretinitis also is an atypical type of optic neuritis, right? It is not seen in association with multiple sclerosis. So in multiple sclerosis, we can see papillitis, we can see retrobulbar neuritis. However, neuroretinitis mostly seen in infectious etiology. So you might have observed that from that time I'm mentioning the multiple sclerosis with optic neuritis. So there is a high risk of multiple sclerosis in patients who present with optic neuritis. So let us see how much is that risk. Okay, so the first thing that you should consider is the age of onset. The patient who is younger, the more is the risk of that patient having multiple sclerosis or developing multiple sclerosis in patients. So younger patients should always raise an alarm. Number two is that women are more prone to developing multiple sclerosis, almost 3 times greater risk than men. Okay, so if a woman comes with optic neuritis, you have to think about in terms of multiple sclerosis. Race, the Caucasians usually have more risk of developing multiple sclerosis, and the northern latitudes have more risk of developing optic neuritis and associated with multiple sclerosis. And clinical features, as I told you, retrobulbar involvement, mild papillitis, and sequential involvement of the other eye within 2 weeks is also a risk factor to developing the MS or multiple sclerosis. So for such patients, it's very important to send the patient for investigations, right? And in optic neuritis, according to the optic neuritis treatment trial, they say that the investigation, especially the MRI orbit and MRI brain to be input, to be more specific, it has a prognostic indication, and it can also tell you about the risk of development of development of multiple sclerosis, right? So we can go for MRI orbit and brain to evaluate the optic nerve enhancement and cerebral demyelination. Now, optic nerve enhancement is not something that we usually send the patients for in an MRI orbit. What what we basically should use the investigation or imaging is to rule out MS and to look for cerebral lesions and cerebral demyelination. So a typical case of optic neuritis will be unilateral and will show optic nerve enhancement. Okay, and this optic nerve enhancement will be seen on the T2 weighted images, fat suppressed images, and usually what we see is a high T2 signal of the optic nerve, right? Now there will be optic nerve enhancement. The optic nerve enhancement could be parenchymal. The parenchymal enhancement, that is the substance of the optic nerve, will look hyperintensive, or just the perineuritis, that is the nerves which are present around it. Okay, the vessels which are present around it, they are going to take up the contrast, and there will be just perineuritic enhancement. So these two types of enhancements can be seen in optic neuritis in case of MRI orbit. However, when we talk about MRI brain, it's a totally different thing. Now, one more thing about MRI orbit, what I want you to tell here is that the involvement of the optic nerve will usually be short segment involvement in case of typical optic neuritis. So what is meant by short segment involvement is that just less than 3 millimeter involvement of the optic nerve will be seen. So along with that, there will be demyelination plaques that we are going to see on the MRI of the brain, right? And these demyelination plaques actually have a prognostic value, and also in assessing the risk of developing the MS. Okay, so just by having a demyelinating plaque on an MRI does not mean that a patient has MS, right? However, we can assess how much is the risk of developing MS. Now, if there is no lesion present in the brain, there is a 25% of risk of developing MS over 15 years. If there is only one single lesion, the risk will increase to 60%. If the lesions are 2, the risk increase to 68, and if the lesions are 3, the risk will increase to 78%. Now, in the diagnosing criteria of the MS, the multiple sclerosis, the criteria that we use is actually the McDowell's criteria, and this has been revised. So according to the latest revised criteria for the MS diagnosis, there are two terms which are used, that is dissemination in space and dissemination in time. Now, dissemination in space means that the patient should have at least one T2 hyperintense lesion in at least 2 of the 4 CNS locations. So to assess the dissemination of space, we are going to actually assess certain spaces inside our brain. You can even remember it like that. And these certain spaces are 4 in number. What are the spaces? Number 1, periventricular space. That is the space around the ventricle, the cortical or the cortex or the juxtacortical, infratentorial, that is where the cerebellum is present, and the spinal cord. So these are the 4 locations. Now we are going to search for hyperintense lesion, right? So demyelination is going to look hyperintensive on T2. So such hyperintense lesion, at least one lesion should be present in at least 2 of these locations, 2 of these 4 locations. So one infratentorial or one spinal cord or one cortical lesion or one periventricular lesion. However, when the patient is more than 50 years of age or has some ischemic disease, what we take for periventricular is about 3 lesions, more than 3 hyperintense lesions. Okay, and for the other things we take usually one lesion. That is what is dissemination in space. So if there's a patient who has at least one hyperintensive lesion in an infratentorial or a spinal cord lesion, for example, then the patient is actually fulfilling the criteria of dissemination in space. Next, what we are going to look at is the dissemination in time. Dissemination in time means that if there is a patient who comes for the first time and we get a baseline MRI and in that we do not see any lesions, and then again we check the patient and now we are seeing new lesion. What does it mean? It means that within this time period of baseline MRI and the new MRI, the patient has actually developed a lesion. That means within that time frame he has developed the lesion, and this is called dissemination of the disease in time. At the same time, suppose we do a MRI in a patient, okay, on one day, and in that MRI we see that certain lesions are gadolinium enhanced, okay. So usually we do an MRI which is along with gadolinium. So we see that certain lesions are showing enhancement and there are certain lesions which are not showing enhancement. Now what does it trigger in your mind? What it should trigger in your mind is that the lesions which are getting enhanced on the MRI are actually the active lesions, and the non-enhancing lesions are the old lesions. Now since there are new and old lesions present on the MRI, and new or old are actually described in terms of time, and that also indicates dissemination in time. Now over here, it does not matter when you do the MRI, whether you are doing it 2 days after, 3 days after, 30 days after, the time frame has been removed from the criteria of diagnosing the MS, okay. Dissemination in time, it is irrespective of the time frame, and these lesions dissemination in space, it is irrespective of whether they are gadolinium enhancing or not, okay. Just the presence of these lesions is enough for dissemination of space, and the presence of multiple lesions of different chronicity or detecting new lesion on the next MRI is enough for diagnosing the dissemination in time. So this was about the diagnosis of MS using the radiology. So this is the image which is showing you the cortical lesions, okay, and over here we can see certain lesion here which is around the ventricle, and the spinal cord lesions, and this is the infratentorial part, okay, the cerebellum where you have to look, and then again in the cortex also we have to look. Okay, now this is a MRI of the orbit, and you can see the enhancement of the optic nerve in case of optic neuritis. However, this is not very commonly done. Now this picture over here shows certain white lesions around the ventricle, so they are called the periventricular white lesions, and since they are looking like fingers because of their organization along the medullary nerves which are oriented perpendicular to this ventricle, these are also given a name which is called the Dawson's finger, right? So they are nothing but the areas of demyelinating plaques. Now on the imaging, what did I tell you? The optic nerve lesions or the optic nerve enhancement is usually short segment. Now if you see a case in which on neuroimaging or on the orbital scans or the orbital MRI, if you see the optic nerve lesion is actually more than 3 mm, that means it's not short segment involving. And if there's a bilateral enhancement, that means both the optic nerves are involved, and enhancement which is bilateral, yeah, and there's extension to the chiasm. Now where is the chiasm located? The chiasm is actually located intracranially, and our optic neuritis typical one is actually limited to the orbits, right? So anything which is enhancing beyond the margin of the orbit or beyond the limits of the orbit and going to the intracranial region also should raise the suspicion about the atypical optic neuritis. So another thing that we do is a CSF analysis. So CSF analysis is usually not necessary for the diagnosis of optic neuritis. However, presence of oligoclonal bands are actually correlated with the development of the MS. Now this was told to us by the optic neuritis treatment trial. And the other thing is the high IgG index. Now the presence of oligoclonal bands actually does not give a stronger risk for MS as compared to those dissemination in time and dissemination of space, and therefore CSF analysis is not that important as a neuroimaging is. Then when we are suspecting an atypical neuritis, optic neuritis, then we have to think about these antibodies, which are the aquaporin P4 IgG and the MOG IgG antibodies. Now let us try to understand certain differences between the NMOSD and MOG. As I told you that the MSON, that is the multiple sclerosis associated optic neuritis, is nothing but our typical optic neuritis. And the NMOSD optic neuritis or the neuromyelitis optica spectrum disease associated optic neuritis, and the MOG optic neuritis, that is a myelin oligodendrocyte glycoprotein antibody associated associated optic neuritis. These two are falling under the atypical optic neuritis, right? However, there are differences in all these three. Number one is that multiple sclerosis associated optic neuritis is usually unilateral, right? However, these two are bilateral. Now, the segment involvement. The segment involvement in multiple sclerosis associated is always short segment, right? The short segment means less than 3 millimeters or focal involvement. And which part it involves? Mostly it involves the retrobulbar part. The MOGON also involves the retrobulbar part. However, the NMOSD will go and involve the intracranial chiasmal part, or also it can go and involve up to the optic tract, right? Now, how do you differentiate this retrobulbar and this retrobulbar? Is that by the amount or the length of the lesion. In multiple sclerosis, it is a short segment involvement that is less than 3 mm. However, in MOG optic neuritis, it is a longitudinal extensive involvement. Similarly, in NMO also, it is longitudinally extensive, that is more than 3 mm of involvement. Now, based on the sign, how can you differentiate? In a case of multiple sclerosis optic neuritis, usually there will be a mild optic disc swelling, right? In NMO also, it can be mild because most of it is involving the intracranial part and the chiasmal part. However, in MOG, although it is retrobulbar, the inflammation is very severe. Now, what is the location of post-contrast enhancement? The optic nerve enhancement will be there in NMOSD. Similarly, in MS or multiple sclerosis also, it will be optic nerve parenchymal enhancement. However, what is specific over here is with respect to the MOG, in which we see this perineuritis or the perineural enhancement. Now, in which type do we have the MRI lesions? In multiple sclerosis, definitely we know that it is very common to have those periventricular, infratentorial, juxtacortical or cortical and spinal cord hyperintensive lesions. However, in MOG and NMOSD, it is not very common. What we see in NMOSD is the spinal lesions, right? And spinal lesion, because what do we know about NMO is that it is Devic disease in which there is transverse myelitis along with the optic neuritis, and therefore we can have spinal lesions in NMOSD, right? Yeah. So the type of lesions again in MS is periventricular, ovoid, subcortical, juxtacortical, and in MOG, that is where there is damage to the myelin oligodendrocyte, the lesions are really large and tumefactive. Okay, they could be cortical or subcortical. Now, in case of NMOSD, you can have hypothalamic lesions, which are more common, right? Along with that posterior fossa lesion, and we will have the spinal lesion. Now, spinal lesion can also occur in multiple sclerosis. However, usually they will not be contiguous, okay? And less than 3 segments of the spinal cords will be involved. Whereas in NMOSD, the more than 3 segments, and that too, there will be contiguous involvement of the spinal cord segment in neuromyelitis optica. So why is this differentiation so important? Let us see. Now, in case of the aquaporin P4 antibody, that is nothing but neuromyelitis optica spectrum, they have a very worse prognosis, okay? And they are not responsive to steroids also. So what do we do for these patients? We have to go for a plasma exchange, in which we are going to remove these antibodies from the plasma and then push back the normal plasma. And along with that, we have to advise the patient regarding the long-term immunosuppression using the antimetabolites or the immunosuppressive drugs. Similarly, in MOG-AB antibody associated optic neuritis, the response is very good to the steroids. Okay, they are going to respond very nicely to steroids, just like multiple sclerosis. However, when you stop the steroids, what happens is that you will see more relapses. So this also will give you a clue that you're dealing with atypical optic neuritis. That means you start the steroids and the patient responds to steroids, but when you stop steroids, the patient is again having recurrence of optic neuritis. So in that case, you have to think about the MOG antibody, and you can actually go for the serum labs and you will see that there is MOG antibody present, and in such patients you should not give steroids, and instead you should put them on lifelong immunosuppression. Right? So that is the importance of atypical optic neuritis, and that is the importance of knowing these antibodies, because the treatment is totally different and the investigations are also totally different. So in case of NMO or neuromyelitis optica, as I've told you before, that it is the antibodies or NMO IgG antibodies which are going and attacking to these astrocytes foot plates. Okay, these astrocyte foot plates are having this aquaporin P4 channels, on which these antibodies are going to come and sit, and then that the complement is going to get activated. And once the complement get activated, a lot of mediators are going to come, and they will cause demyelination and finally cause the necrosis, right? So for the diagnostic criteria of NMO, there should be a history of optic neuritis, number one. There should be a history of acute myelitis. Okay, that means the transverse myelitis. That means the patient will have paraplegic symptoms, paraparesis. Okay, then along with that, two of the following three should be present. That is, number one, MRI of the spinal cord will show involvement of more than 3 segments, and then NMO IgG antibody should be positive, and the brain MRI should not be consistent with MS. That means you should not see those typical lesions with MS, that is the periventricular and juxtacortical and infratentorial. Instead, in case of NMO, the lesions that you see are the hypothalamic lesions or the posterior fossa lesions, right? So any two of the three will give you the diagnosis of NMO. Then what happens in any optic neuritis is that finally, after damage, as we know that the nerves of the our optic nerve, they cannot regenerate. So ultimately we are going to have optic atrophy, and it is going to look very similar to that of the post-papillary edema optic atrophy, in which it will look like secondary optic atrophy, in which we'll have the dirty gray color of the optic nerve. And however, sometimes in patients who have retrobulbar neuritis, because there are not much signs present in the disc, what we are going to have is signs of primary optic atrophy, which will look which will not be so dirty white, and it will be actually described as white optic atrophy. And sometimes the optic atrophy might be so mild that we might actually have just a temporal pallor, right? So this is a primary optic atrophy, okay, or it could be seen actually in patients with retrobulbar optic neuritis, okay, and you can see that the temporal pallor is more compared to the nasal pallor. Now, so in case of atypical cases, I told you already about the labs that you have to do and how do you differentiate it from the imaging. And then there are other investigations also. Remember that I told you there can be infections which can lead to it, and there can be autoimmune causes like SLE which can lead to it. So you might go and want to investigate if all these things are coming negative. So you can go for a complete blood picture, estimation of rapid plasma reagent for syphilis, CRP, ESR. Okay, then we can go for FDA, ABS test, anti-nuclear antibody for the connective tissue disorders, right? So these are the additional testing. So in my next video, I will go in details about the treatment of typical and atypical optic neuritis. So if you like this video, kindly give it a thumbs up and share the knowledge, and stay tuned for the next lecture on the treatment of optic neuritis. Thank you and have a nice day.